To let him in, or are you letting him in? You're letting him.
Yep, here we go.
Can I close this?
Mm-hmm.
Yep. Oh. Okay, I'm gonna ignore that.
All right. And we're on.
Great.
Shall I take it away?
Can anyone hear us?
Can everybody hear us okay?
Yep.
Fantastic. Great. Nice one, thank you. Great to see so many people online. So just want to say a big warm welcome to our very first ever webinar. With that being our first, please be kind to us. We're hoping the tech will work 150% correctly, but if not, let us know. We'll look to get it sorted out. So just to introduce myself, I'm Emma, I'm CEO of Swaltech. And for those that don't know, Swaltech's based here in Christchurch, New Zealand. We're a small but mighty team, and we're developing technology for patients experiencing swallowing impairments. So the plan for today is that Maggie-Lee is going to talk for 30 minutes. And then from there, we're going to open up the floor for questions. So once we do that, we want you to put your virtual hands up. And Ella, sitting behind Maggie-Lee here, will facilitate answering the questions. So when we get to question and answer time, to support us, we have the following people in the room. So right behind me, we've got the very lovely Eric Knapp. Eric is our human factors advisor, effectively a patient advocate who has shared his lived experience with us as we've developed BiSSkApp. At the end of the table, we've got Darcy Madron. He's the software engineer who's been behind developing the patient app and the clinician portal. We've got Ella Waswo, who's our marketing coordinator. And finally, of course, we've got Maggie-Lee and myself. So just some quick house rules. If everybody could please put themselves on mute while Maggie-Lee is speaking, that would be great. As well as that, we won't be covering pricing today. We're just covering the tech from a clinical and technical perspective. So if people are interested in making inquiries about the product, you can book a demo with us on our website. So that's all from me. So I will hand over to you, Maggie-Lee.
Very good. Thank you. Let me see if I can figure out how to share. I didn't practice that part at the beginning, and I have a very strong dislike for Teams. So sorry, I will get there. Okay, share.
Is that permissions thing?
Yeah.
If you go out of that and then
Do you want to
refresh
just-
it.
Apologies, everyone. You would think I had never sat in front of a computer before. This is the only reason that I developed technology in my research, was so that there would be justification for hiring an engineer to do everything for me.
Now I need to remember where. Aye.
And this is why I hired engineers to do everything for me, Darcy. No pressure.
That would be great.
Can
I
you
see
share
some
the window?
familiar names out there. Oh, there's Steve Wakefield.
So team, we're just gonna have to restart Teams from Maggie-Lee's computer real quick. So we'll be right back. Oh, can I get your thumbprint? No, whatever it is. Right.
Oh, we're shared. Good.
Is it that one?
Lovely.
David.
Here we go.
Our sound is on. Yeah, great.
This is always the stressful part of public speaking. I don't mind public speaking, but I do mind trying to negotiate all the tech beforehand. So thanks to everybody for, there's not seeing the right thing.
It's showing the screen that you're showing.
Okay, oh, one of the,
If you
yeah.
click this,
If you click slideshow, down the bottom, like you normally would.
There we go.
Oh.
There you go.
There. Now we've made it. All right. So I guess I wanted to talk to you today about, I've been working on this project for a while. And I think in many respects, a lot of what BiSSkApp promotes is a bit of a different way of doing clinical practice. And so I've titled this Translating 50 Years of Research to Redefine Rehabilitation. Let me make it very clear that I didn't do those 50 years of research because I'm just a spring chicken and couldn't possibly have been collecting data for 50 years. So I want to sort of dive in though and talk about what we've done historically that has brought us to the point that we are today, because I think that's quite relevant. And indeed, I love this quote by Churchill, who says, the farther backwards you can look, the farther forward you can see. And I think that's very much true. And maybe I just say that to justify my aging self. However, I think that we learn a lot from trying to understand why we've done things previously. So I guess in understanding where we're going, we want to start way back at the beginning. So in the beginning, there was a brainstem. And the foundations of our understanding of swallowing neural control were based on very early work about swallowing by Andre Jean and Art Miller and others, who identified that swallowing was controlled by a medullary central pattern generator. Had two nuclei in the brainstem, the nucleus ambiguus and the nucleus tractus solitarius. Those two nuclei work together to take in sensory input, send out motor output. Now, what's interesting about this is that even though they identified swallowing was controlled by a central pattern generator, people continue to call swallowing a reflex, that it's reflexive behavior. And a CPG isn't too far from a reflex, but it's not the same thing. When we look at management at the time, there we go, our management approaches were quite consistent with our knowledge at the time. Swallowing is a reflex, either that or a CPG. The general thinking was, and probably still is, that you can't change a reflex. So our management relied very heavily, initially on compensation, but eventually we added peripheral strengthening techniques with the idea, and this was about like in the late 80s, I suppose, early 90s. The idea was we may not be able to change swallowing in terms of how that swallow is executed, but we can make the muscles stronger. And if we make the muscles stronger, then when the person attempts to swallow, perhaps that additional strength will facilitate greater bolus transfer. So we started out with this very sort of delineation of swallowing's a reflex. All we can do is either compensate for the problem with diet changes, chin tuck, head turns. All of you know all of those very well. And we can add in peripheral muscle strengthening. And I'm presuming that many of you, if not all of you, know our peripheral muscle strengthening exercises very well. But then a little bit later, Ruth Martin came along and published this manuscript, The Role of the Cerebral Cortex in Swallowing. And Ruth published this manuscript identifying what all of us probably had seen but didn't take on board. And that's that when we look at lesion studies or patients who have had dysphagia and you look at their lesions, many of our patients with dysphagia have cortical strokes. And so she posited the question, which was quite the controversy at the time, like, who is she to do this? That indeed it's not all about the brainstem. So our early work said everything with swallowing happens at subcortical levels. But Ruth is saying, I don't think so. If you look carefully at the literature, maybe that's not true. So moving forward, ensuing research and a bit of common sense suggested that man cannot eat by brainstem alone. And indeed, even Andre Jean, this is a copy of his model from his early research. Well, later on in life, he thought, oh, yeah, maybe there are supramedullary inputs. And so he's acknowledging that we still have our brainstem control, but the cortex plays a role. Now, over the past decades, our models of swallowing neural control have gotten much more complex. And you can see if this one from Ertekin, he's got almost as much cortex as he does CPG. Ertekin was really the first to differentiate between voluntary swallowing, or what he termed corticobulbar swallowing, and spontaneous or reflexive swallowing. So he's really the first to sort of acknowledge in print that, yes, we can swallow reflexively and swallow our spit, if you will, or we can take in food. We can have ingestive swallowing. And those are two separate things that utilize similar neural structures. Moving forward, we have yet even more complex models. But you'll notice over the course of the 3 or 4 models I've shown you, they're all moving up to the cortex. And in this one, we've only got a tiny little region down here that's controlling swallowing, and then lots of cortical structures that are contributing to the swallowing response. Now, coinciding with this understanding of neural change, we also had an increased interest in neuroplasticity. And I would presume that many of you have read these articles. The first, the one on top by Jeff Klein and Teresa Jones. And Klein and Jones went back to the literature, the neurophysiology literature, to find out what things can facilitate experience-dependent neuroplasticity. And he's outlined all of those in this manuscript. I think it should be absolutely critical reading for everyone. Then the other manuscript, Joanne Robbins and many other people looked at Kleiman Jones' work, and then they translated those principles into clinically oriented swallowing practice. Again, really important article, and I think anyone that is keen on looking into the skill training component, which we'll talk about a bit further on, these articles really are fundamental readings for you to understand what skill training is actually trying to accomplish. Now, all of this work to this point raises a very fundamental question. If a source of dysphagic presentation is in the cortex, the brain, then why is our primary focus of treatment on the muscle? So we do have people who have dysphagia specifically from muscle problems in the case of myopathic patients. But most of our dysphagic patients have brain damage. Can we develop options for rehabilitation that are targeted toward changing brain? And I think that these questions really sort of sing out following the historical path that we've been on to get to this point. We also have some associated questions. We usually need to strengthen something if it's weak, but is weakness always the underlying cause of dysphagia? And I think that if you think back through all of your clinical cases, and I can say this for myself, back when I was still in clinical practice, get a dysphagic patient, I do muscle strengthening with them, muscle strengthening. But when I think about those patients, they weren't all weak. And in fact, I don't think many of them were weak. I think there were other issues. Now, when we look at dysphagia, we tend to describe dysphagia in terms of biomechanics. The patient has a pharyngeal phase impairment characterized by decreased anterior hyoid movement, resulting in poor epiglottic inflection and UES opening. Those are all biomechanical changes that we see in the pharynx on fluoroscopy or endoscopy. The problem with biomechanics is it doesn't get us to a low enough level when we're trying to think about treatment planning. So just because the hyoid doesn't move forward, we need to understand the pathophysiology of that. Why did it not move forward? We have presumed for about 50 years that the hyoid doesn't go forward because of weakness. But is that true? And indeed, if you look in other areas of physical medicine and rehab and in our own area in terms of the dysarthrias, we've got dysarthrias coming out our ears, flaccid, spastic, ataxic, apraxis, a couple of other dysarthrias that are all very well defined in the literature. Very frequently, we understand those based on acoustic determinants, so we can hear the difference between a flaccid and a spastic. However, when we look at dysphagia, trying to specify, do we have anything like a flaccid dysphagia? Has that term been coined and defined? Do we have a spastic dysphagia, an ataxic dysphagia, or apraxia of swallowing? There are a couple of references in the literature to apraxia of swallowing, but they tend to be very heavily focused on oral phase impairment and some discoordination in transferring the bolus out of the oral cavity and into the pharynx. Hyperkinetic and hypokinetic in all of our Parkinson's patients that we tend to do a lot of muscle strengthening with, are they really flaccid, or are we seeing in them hyperkinetic and hypokinetic dysphagia? No one's coined those terms or done the hard yards of looking at all these patients and saying exactly what is this? Is it hyperkinetic? How does that present? Is it hypokinetic? How does that present? So for the most part right now, we just have dysphagia. So we've got 7 or 8 dysarthrias and we have dysphagia. There's a real lack of specificity. Now, David Padovar has published this model, I guess, of organization of motor control, where he talks about the pyramidal system, the extrapyramidal, and the sensory system. And then if you follow each of those colored lines, damage to each one of those systems can result in a variety of pathophysiologic features that would control the biomechanics of swallowing if we had done that work. But unfortunately, at this point, nobody's taken one of our models of swallowing and tried to put it on the models of motor control. And so we just got dysphagia. And I guess I spend a lot of time on this because I think that when we look at dysphagic patients, if indeed they're all weak, then doing muscle strengthening is absolutely appropriate. However, if they're not all weak, we need to be thinking about why and what is the fundamental problem so that we can identify treatment. Until we do that work, at least in my brain, I kind of separate out our flaccid dysphagics, if you want to call them that. Those are strength impaired patients. They present as weak. So you might have a lateral medullary stroke, a Wallenberg kind of patient who has lower motor neuron damage. They will be weak. We know that lower motor neuron weakness. Upper motor neuron, if it doesn't affect other structures, will also be weak. But everything else is still a bit of a mystery. Is there such a thing again as a spastic ataxic dysphagia or apraxia of swallowing? Now, these 3 categories of motor impairment are are all generated from damage to cortical structures, and they contribute to either motor execution or motor control or motor planning. And so all of those things I've sort of lumped under the category of skill impaired. Now, so if we need to rethink rehab, if we think through what I've talked about to this point, we need to start shifting our focus, or at least expanding our focus from the muscle to the brain. First attempts at that have been very much from non-invasive brain stimulation techniques. So repetitive transcranial magnetic stim or transcranial direct current stim, they've gone a very long way to shift our focus from the muscle to the brain. However, there's a lot of limitations. They're expensive, at least for RTMS. They are, in my view, invasive. They're called non-invasive brainstem techniques. But I believe when you're externally stimulating somebody's neuron, that has a little bit of invasiveness in it. Did I hear somebody? No? Okay, sorry, I'm hearing things. There are also significant training issues. Well, there are significant training issues for everything we do, but stimulating brain, I think they're a little bit bigger. For me, the biggest issue is they lack specificity. If you do TMS or RTMS, you find a region of the brain that's heavily involved in swallowing and you zap it. If you have a patient with decreased UES opening, does it help that? Don't know. You're just stimulating the brain and hoping at the other end of it, something significant clinically falls out of the bottom. So I think a different approach would be to look at volitional modulation of the cortical activity related to swallowing or swallowing skill training. And there are any number of references in the literature over the last couple of years that have addressed this. In our lab, we've used manometry to control the timing and sequencing of pharyngeal pressure generation and UES opening. UES opening has also been looked at by Nativ Zeltzer in a lab in California. Surface EMG to control force and timing. That's come from our lab. It's come from a place in the UK. It's come from other places around the map, some in Australia as well. Respiratory tracing and EMG for swallowing respiratory coordination. Bonnie Martin Harris, who many will know of her name, is doing some really, really interesting work on teaching patients to swallow at a different phase of the respiratory cycle. And then there's some very new emerging research on upregulating the cough response. So I think that not just me, thank goodness, but quite a lot of people are starting to think, hey, wait a minute, maybe it's not all about strengthening. Maybe we need to look very carefully and very specifically at what in the pharyngeal response is not working and how can we address that. So I'm going to go now, I'm going to shift back to another in the beginning, but I want to talk very briefly about my journey that has taken me from being a clinician up to the point of starting a med tech company some years ago. It certainly was not the path I intended to take, that's for sure. So this is me back in the days when we had big hair in Texas, and I was a brand spanking new clinician, but I was really intrigued as a brand spanking new clinician about how we could do really better.
Sorry, I think someone.
Can we just ask everybody to go on mute, please? Excuse me. Yeah,
Okay.
right, thank
Here
you.
we go. Sorry. So back in those days, I borrowed some EMG equipment from physiotherapy. This was back in the early to mid 80s when I was early in clinical work. And I started trying to figure out, is there a way that we can alter swallowing using SEMG? At that time, we still thought of swallowing as a reflex. So I spent my time working on the muscles engaged in swallowing? And is there a way that we can change those muscles? And then if we move forward another however many years, probably another close to 15, 16 years, I met this wonderful woman named Deborah. And Deb had a foramen magnum meningioma that was resected. She had a really, really difficult course. I didn't get her for treatment until about 2.5 years post onset. And at the time I got her for treatment, she is one of the 5 now patients that I think had absent swallow. She had no organized motor response. And of course, this was back in the 90s, and I thought, well, heck, what am I supposed to do about this? If she doesn't swallow, even though I used EMG a lot to work on muscle strengthening at the time, if she doesn't swallow, how do we do effortful swallow if she doesn't swallow? Didn't quite know what else to do, so we did effortful swallows with the EMG. And after about 3 days of very intensive training, an hour twice a day, she came in and she said, I'm swallowing now. And I thought, yeah, right, you are. And indeed, when I gave her some yogurt to eat, she wound up with yogurt in her belly. So she was swallowing by that point. It was still very impaired, but she went on. After 6 months, she got rid of her feeding tube, returned to a near normal oral diet, and has been doing very well ever since. We've seen her fairly recently. And so Deb raised a lot of questions. I thought I was doing muscle strengthening with her because my 1990s brain said that's all we can do. And so we did that, but we used EMG so that she was watching herself swallow, watching the line go higher and adjusting that. So the focus was effortful swallows, but in the end, it changed the organization or the pattern of her swallowing response so that she was able to recover. And that certainly led me on a path that took me to Vienna to do my PhD, looking at the role of the supplemental motor region in swallowing. Many of you will know that the supplemental motor region is responsible for motor planning, of voluntary motor behavior. And so I thought I would go and look at the SMA and research. And so I did sort of a very clinically scientific project, if you will, and found that indeed the supplemental motor area is very heavily activated prior to volitional swallowing, and that SMA information from the SMA appears to transfer directly to the brainstem and out to the peripheral muscle. So that got me really interested in voluntary control of swallowing. I moved to Canterbury in 2000, and it wasn't too terribly long after that I met this young man, Eric, who is not quite as young a man anymore, neither am I, as a matter of fact. So Eric had a series of strokes when he was about 33 years old. We looked at his swallowing and we found a really curious thing. Eric is one of these funny people, sorry, Eric, that when he swallows, instead of squeezing the pharynx from the top to the bottom, everything contracts at once. So we needed to address that problem. And the only way I could figure to address that is we placed a manometry catheter in his nose. And with manometry, you would have seen the images before. You get 2 waveforms. And the idea is I want you to watch those 2 lines and make the blue line come first. Well, subsequent to Eric did very nicely with treatment, and I think he's still swallowing, so he hadn't told me otherwise. So Eric has done very well with that. I published a manuscript reporting on 16 patients with missequencing, and they did, as a group, did very, very well in return of swallowing function. So along about that time came Esther. Now, Esther, we hired at my research lab, thanks to a very generous donor. We hired her as a mechanical and computer, or as an engineer, to help us develop technology where we could really focus on the skill of swallowing. I know that most of you, probably maybe even 96% of you, don't have manometry. It's expensive equipment, and it's also a little bit invasive, so it's not very comfortable for patients. So we needed to see if we could come up with something that was a little cheaper than $100,000 that patients could use to get feedback about their swallowing behavior. So we came up with a research tool called BiSSkApp, and we used it in our research in the lab. BiSSkApp is a desktop device that uses a separate wired EMG, and it gives you a waveform on a screen. So it's a waveform. The patient in this image is trying to put a hamburger in the mouth. So they need to do a swallow where they swallow and they hit the target. So that was BiSSkApp. We mostly developed it for research, but we put it on the university website. Strangely enough, people seemed to want it. We got really, really good feedback about BiSSkApp. A lot of people really liked the approach of skill-based training, but they're not resourced for intensive training. And we heard over and over again, I know I need to be doing this every day, but I can't see patients every day. That just seemed it didn't work in their healthcare system. Purchasing separate components was annoying. They got software from us, they got the EMG device from somewhere else, they got the electrodes from somewhere else. So that was a bit of a problem. And the wired technology introduced noise. About that point in time, at least in New Zealand, and I understand in Australia as well, and could be other places, there was a big push toward decentralized healthcare, so that healthcare systems, as a way of cost cutting, healthcare systems were trying to push patients out of the hospital to be managed either in medical offices or in their home. So the big push was trying to get patients out of hospital and deal with them elsewhere. And so seeing patients in an acute stays might be decreasing in length, and the patient winds up at home. That's good for the patient because they get to be at home. In a lot of respects, although it may decrease cost at the hospital level, it poses a very big problem for clinicians to get into the patient's home often enough to do rehab that is needed, to do enough rehab needed for functional change. And then sure enough, shortly after that, we had this little critter pop up in our world. And so everybody had to stay at home more in other places than in some places than others. But COVID came along and really did two things. One, it emphasized that we need to come up with tools for home training because we can't see patients face to face. And two, it made telehealth options because of that much more acceptable and into the realm of, at that point in time, almost usual practice. So BiSSkApp, we decided then that based on all of this information, that we would make an attempt to commercialize BiSSkApp. And the key points of BiSSkApp are that the patient can complete intensive rehabilitation without taking up a lot of clinician time. So there's efficiency without compromising care. One clinician is able to see several patients at the same time. They're all getting intensive rehabilitation, but it's not taking as much time from the clinician. And in addition to the strength protocol that had been previously done with EMG, skill-based swallowing training encourages precision in motor behavior or the modulation of swallowing. It's a more contemporary approach. So BiSSkApp has a couple of components. For most of the clinicians, the first port of call is going to be the clinician portal. And so if you, as a clinician, you get access able to get real-time updates on patient activity. You can adjust the treatment plan ongoing. So if you see that the patient has had a difficult session, not done very well, you can adjust the treatment plan to make it easier for the patient so they're more successful. If you work in the healthcare system, you can transfer patients to other departments or clinicians. So if a patient is in acute care and you start seeing him acutely with BiSSkApp, he can then take his device to rehab, and a clinician can access that patient through the portal and get continuity of care from acute to rehab to home. All of the data then is downloadable. So in the clinician portal, that's sort of your place where you set up treatment plans, you monitor patients' progress, and then you adjust things. The software hardware package, there's a sensor, the little orange thing at the front, that sits inside a docking station, which is plugged in. So it recharges when it's in its docking station. It comes with biocompatible adhesives to stick the sensor to the chin. And then there's a patient app that connects to the sensor via Bluetooth compatibility. So there's no pesky wires to put artifact in the signal. So a patient then would be trained by the clinician in the clinician's office. That training with a really good patient, and I think most of you will know what I mean by that, that training may not need to be more than 1 or 2 sessions in the office. For some of our other patients, you may need more hand-on-hand training. But the idea is once they are trained up to use the device, the patient takes the device home and you monitor him through the portal. That patient then may come back and see you once every 3 weeks or once a month, once every 6 weeks. So you'll still monitor the patient. You are still that patient's clinician, but the patient is doing rehab on his own with the support of his family. And I guess when we talk about redefining rehab, the use of BiSSkApp really requires quite a bit of a change in thinking. And I think part of that is sort of some of the things that I think are quite significant changes for some clinicians is that we don't have to do muscle strengthening with everybody because not all dysphagia is due to weakness. And many of our patients are going to do much better if we don't strengthen them, but we work at how they're recruiting the muscle, how precise they are in muscle recruitment. We need to remember that the muscle is driven by the brain. So if the brain is broken, you're going to have a down-on effect on the muscle. I think the use of biofeedback is really, really critical. It's that thing if you can see what you're doing and you can imagine how to do it correctly, you can change it. There are already a couple of articles published in the dysphagia literature about imagined movement, relative to swallowing, how that affects brain, and how that affects performance in terms of lingual function. So I think that the use of biofeedback is critical. We want to give patients knowledge of performance and knowledge of results so that they can change their motor behavior. I think another shift is that we're going to patient-owned rehabilitation, for lack of a better term, where the patient isn't a consumer. He goes to his office or private clinic, he pays a fee, he gets his treatment, he goes away. He goes back, he pays his fee, gets his treatment, he goes away. Whether it's fee paying or whether it's in the healthcare system, it's that patient going and consuming rehab. Instead, we're setting up the patient where he's in charge. He's the one doing his rehab. He's getting feedback from you, but he's responsible for his rehabilitation. And I think a lot of patients get a big benefit from owning it because they're more responsible to execute it, as long as they have a therapist in the background kind of kicking them up the backside if they're being lax. We're very important in that regard. We also know that intensity matters. The greater the repetitions, the greater the effect. And that's been proven over and over and over again. Exactly how many repetitions or how intensive, that we don't know yet. That information is still outstanding. And so I think essentially we need to find better ways to have more efficient utilization of clinical resources. If you're using something like BiSSkApp, or let's say BiSSkApp, since that's why we're here, then it allows you as the clinician to not see a patient one-on-one, but to see a lot of patients once or twice one-on-one, and then they do their treatment at home and you just check them online. So it's a more efficient utilization of resources once you get past the training phase. You know, it's funny when I talk about going around, circling back around, and you have to understand the past to look at the future. I love this quote. Chuck Larson was a speech pathologist in the United States. He published in 1972. He's even older than I am. So he published in 72. He says, the patient is taught the importance of regulating his swallowing volitionally rather than on a reflex basis. In other words, swallowing is made subject to intellectual control. He will be thought to think swallow and then swallow. And it's like so many of the principles that in my research program I've been exploring and trying to develop. And to be honest, I kind of thought it was my idea. Well, actually, it wasn't. It was Chuck Larson's back in 1972. And so I think there's the importance of looking back so that we can move forward. So I'm going to stop talking and stop sharing. And I guess we open it for questions at this point.
Absolutely.
And then do you want to just remind us the process for?
Yeah, so on your Teams app, there's a little button with a hand on it that says raise. So if you click that, it'll pop up on my screen in order to say, yep, this person's got a question, then raise their hand. We'll get through as many as possible, but if we don't get to your question today, you can go on our website, submit something. We're really happy to help.
Do you want to take off the?
Oh,
So we can see faces.
I thought I did stop sharing.
All right.
Oh, you mean just close
Yeah.
this? I get it. Sorry. Yes, because I've never touched a computer before.
All right, we've got a question from Annabelle Vaughan.
Hi, Maggie-Lee and team. Thanks very much for your presentation. I was just wondering, and apologies if I've missed it, with BiSSkApp from memory, the participants or the patients are doing saliva swallows, not food and drink.
Right.
With BiSSkApp, is it similar? You're doing sort of dry swallows and not doing it with food and drink? And if so, how do you, I guess, two parts to the question, what's your findings with it transferring to improvement on food and fluid swallows, and how do you, what's the kind of your hypothesis for that transfer of skill?
Yeah, absolutely. That's a really great question. And I hear that question a lot. This is not the first time I've heard that. So we do with BiSSkApp, we tend to do training with dry swallows. Now we've had a lot of discussion in my research group about, is that the best way to go? Because of course, yes, we want people to swallow their own secretions, but we want them to swallow a whole lot more than their own secretions. And so we've thought about trying to develop protocols where they do take food in. The difficulty with it is that if you have a patient that's particularly dysphagic, and especially on the skill-based component, where the line goes across the screen, they need to swallow at the right time and with the right amount of force generation to hit the target. But maybe the bolus they put in the mouth doesn't dictate that timing or that force generation. So I'm concerned, we have always been concerned about having them do bolus swallows when they're training, because I don't want to force them to do something or have them do something that may affect the efficiency of swallowing. So our focus has always been you do a block of training, which may be 10 swallows, 15, and then you take a little break. And in that little 2 to 3 minute break between blocks, or 90 seconds or 5 minutes, you say, okay, think about what you were just doing, but now take a bite. Take a bite, think about swallowing, take a bite. Then you go back to your screen training, and then you go back to oral intake. If you look at the published research, the Apicorella study, where we did only dry swallows, and we actually didn't do intermediate bolus intake, saw improvement in all of the outcome measures except for hyolaryngeal movement. But all of the functional outcome measures improved quite significantly after treatment. So the Kleiman Jones article, they talk about transference of skill, where if you train one thing, it will shift over to others. We see that in the dysphagia literature, where people that do LSBT, there are 2 manuscripts reporting, look, they had improvement in swallowing because of LSBT. Well, of course they did, because you're working on the larynx and closing the larynx and airway protection. And so, which affects airway protection. Do I think that that is a treatment for swallowing? No, but it's a good example of transference. When you work on one thing, it can transfer to other skills. Sorry, long response, short question. There you go, next. Sorry. It's nice to see you, Annabelle.
We've got a question from Benjamin. It's probably for Emma. Do you distribute / sell BiSSk to Australia specifically? Oh, sorry, Asia, specifically Singapore.
Not at this stage. We're exclusively in New Zealand and Australia, but we will look at going to Asia in the future.
Another one from Neelam. Have you had success using this app with individuals with severe dysphagia on a background of scleroderma with polymyositis?
Ooh, doggy, that's one. I tell you what. Specifically, no, I have not used it with somebody with that etiology. Certainly doesn't mean I wouldn't, but I have not. That's quite a complex situation that leads to dysphagia. So I haven't replicated that specific thing. I think all of those etiologies, what were they again? Say it again.
Scleroderma with polymyositis.
Polymyositis. I certainly wouldn't do strength training. I'd probably do skill. With scleroderma, you tend to have decreased range of motion, not because of weakness, but because of tissue change. So it might be very good to keep the tissue moving.
This probably one for Darcy. From Kate, is the sensor reusable across patients, or is it a single device per patient?
So this kind of question comes back to how we want the device to be used. You can, between your patients, share the sensor, obviously give it a wipe down and things, clean it up. But a key point Maggie-Lee was putting down before was we want to try and shift towards giving patients the autonomy to perform rehabilitation, which would mean leaving the sensor with them and letting them do it. Again, you can clean it and can use it between patients though. I don't know if that answers.
I see, Kate, you also asked about the cost per sensor. If you are interested in inquiring about a purchase, we'd love for you to book a demo on our website. There's another one from Verity. When and where is it available to purchase in Australia?
It is available to purchase from anywhere in Australia. So if you're keen to learn more, as Ella just said, just inquire via the website. We'll set up an individual call with you.
One from Claire. Is there a specified age range for use of this app?
We've put our focus on using this with adults. And so sort of because I'm an adult person. I mean, I work with adults. I'm one of those clinicians that has been focused in the adult population. However, having said that, although we've sort of focused this on adults, We have used BiSSkApp, the predecessor, on 1 or 2 kids in the lab who have done very, very well. One was 10. The other one, I think, was 5 or 6, if I'm not mistaken. I don't remember exactly because I didn't actually treat them. And we did a little project a couple of years ago where we brought in some healthy children, 4 to 6 year, no, yeah, 4 to 6, 6 to 8, and 8 to 10-year-olds. So in 3 age groups, normal healthy kids. We only did 1 session. Our question in that project was, could they all actually do the task? So could they swallow and hit the skill-based target? Could they swallow and swallow harder? So the whole focus of that wasn't to see if they improved because they're normal kids. It was just to see if they could do it. And sure enough, all of the kids were able to do it. The parents came with them, of course, and said, I think 30 minutes is probably about enough. They understood what they were supposed to do. The youngest child in that research cohort was 4 years, 2 months old. Yeah, they did the worst job on performing the task. They knew what they were supposed to do, but they didn't really do it very well. So I have always wanted for someone, not me, but for someone to do a study in kids with cerebral palsy. I've worked with an adult with cerebral palsy who appeared to have a lot of flora of mouth, increased tone or spasticity, if you want to call it that. I'll say it's increased tone. She did beautifully with using EMG to teach her to calm her muscles and then swallow. So I'd love for somebody to pick that one up and do that in kids with cerebral palsy.
That's perfect, because that hopefully also answers your question, Rushali, about use in children, specifically with cerebral palsy. And you also asked about post-critical medical conditions like seizures and meningitis. So I think that covers that pretty well. Chantel asks, what was the main thing that differentiates BiSSkApp from other ECMG devices? Is it just patients being able to use it independently, or are there other key features as well?
I think the big difference is that with other EMG devices, which I have used over the course of my many, many years in this area, other devices are developed for other things. Many of the devices that I begged, borrowed, and stole from physiotherapy, you would have a little device with either wired or unwired electrodes. And then your screen is very small. It's about the size of an iPhone. And you don't see a waveform, you just see an LED light that goes up and down. It's not very useful. It has some use, but it's not as useful as a time by amplitude waveform that the patient can learn to control. BiSSkApp is also set up very specifically for swallowing. So it's not a device that was developed for something else that we've sort of pulled over into swallowing. We've developed it quite specifically for swallowing with an electrode that fits under the chin or the floor of mouth electrodes.
It's also non-stimulating.
There's a lot of physio ones that aren't too, but it is non-stimulating.
Is it BiSSkApp being a differentiator?
Right.
Yeah.
Okay, Kate also asks, is there a limit to number of patients that are able to use the app per clinician license?
Say that.
So if you've got a clinician
Yeah.
license, is there a limit to the number of patients that can be under that clinician license?
No, there isn't a limit. The limiting factor will be the number of patient licenses you have available to you. And that might vary based on the setting you're in. So would encourage you to reach out to us directly so we can talk about what that would look like for you.
I'll chime in there, and I'm not a clinician or a researcher, but you're also probably limited by the number of patients you can see at once, right? You wouldn't be able to, if you couldn't have 100 patients as a clinician kind of going on at once.
Not if you intended to sleep, you couldn't.
So if that's a factor too.
Yeah, there we go. I think that if you look at that, some of your patients, as you all know, some of your patients will be quite high needs patients, which might mean, yes, you can send them home with the device, their partner spouse, husband, grandchildren, whoever can help them with the manual components, but you may need more monitoring on those kinds of patients. Other patients, I would envision that, say, in the Parkinson's population, you may have patients who very, very early on in Parkinson's disease decide that they want to do exercises maybe 3 times a week. They have a device that you have taught them to use. They take it home. They're not going to need a lot of check-in. They know what they're doing. They're cognitively intact. And so those patients you wouldn't see near as often as you would an acute stroke patient or tumor resection or other etiologies.
Tori asks, would the app differentiate if the swallowing muscles are weak or uncoordinated due to something like ataxia?
Oh, love that question. We did some research a couple of years ago. Karen is a PhD student of mine, and we tried to develop a little test using EMG to see if we could do exactly that. Could we differentiate who was poorly skilled from who was poorly strengthed, for lack of a better term? That's not really a word, but anyway. That was the point of her PhD research. And we developed this little test, and she executed on myopathic patients, healthy patients, and stroke patients with the hypothesis that the healthies would look normal, funny that, the myopathic patients would appear as weak, and the stroke patients would appear as either weak, poorly skilled, or both, just because of the nature of cortical stroke. And essentially, the test we developed did a great job when we did a cluster analysis of finding the healthy people and finding the weak people. When it came down to the poorly skilled people, almost all of them also appeared to be weak. So is it that they're really weak, or they can't generate muscle strength because they don't have the skill to recruit the contraction needed to do that? That part, but the test didn't differentiate. So that test, although it's been published, I don't necessarily recommend jumping on board and using it, because I think we need to refine it a little bit more before we believe it. So if anybody out there wants to come get a PhD and work on developing that test, just give me a call. That's wearing my other academic hat. Sorry about that. Whoops.
That's all right.
We've just got 1 more minute left, so I think Annabelle's will be the last question. Have you done or heard of any studies comparing the effectiveness of that external device-based biofeedback versus a bolus-based rehab alone?
No, those data don't exist at this point. It doesn't mean they won't in the future. I guess, you know, the bolus, the rehab with bolus-based rehab, I think. The tricky one about that is that you have to get them to the point that they can take a bolus. And so I think one of the very good things about BiSSkApp or by using biofeedback is if you have patients who are at very high risk, you can start rehab to get them to the point of being able to accept a bolus. I would say then, I mean, my fundamental bias, and I will own this as a bias from my son, however many years experience, 40 some odd years experience, is that if you're just giving a bolus and looking at sort of similar to MDTP, that kind of approach, you're doing graduated boluses, to my understanding, which I think is great. I don't think there's anything wrong with that at all. But I think that if you can give a patient something to see and really focus on, then I think they do better, in my opinion. So that's not a proven point yet, but I guess I would want to start at least with this. And of course, certainly as patients improve, you get them started eating as quickly as you can. You don't only do this, you do this and oral intake as they're able to.
That's us. I think that's us for today. Sorry, I know I've got a couple more questions there, but totally reach out to us by email, our social media.
Can we take those questions, keep them after this and respond?
Yeah.
Yeah, great. We'll look to do that. Just a big thank you for sticking with us, particularly as we navigated the use of Teams at the start of the session, but appreciate those who jumped online for your engagement and great questions today. So thank you very much, and hopefully we'll be hearing from you in the future. Thank you.
Okay.
Bye.
Thank you. I think I saw Peter in there too. Hi, Val. I see some other Sarah and Keith. There we go. It's quite nice to see you all in there. Lisa, Francis, there she is.
Hello, Maggie-Lee.
Hello,
And we
Lisa.
saw Deanna in there too.
Oh, is Deanna in there?
Not a different Deanna who wasn't Lisa. Right.
Right.
All right. See you, everybody.
Very good. Bye-bye. Just nice.